Mm. All right, good job on your quiz, everybody. All right, so for today, so if you remember from the announcement, since we don't have class next week, we're going to cover week 8 and week 9 material this week. So we're going to start with critical thinking. Some I know you heard that term before. So tell me, what is critical thinking?
Using your best judgment.
Okay. Using your best judgment. And how do you develop critical thinking skills?
Right, by understanding what's happening when it starts and your like immediate response to how to handle the situation.
Okay. And so it's based off of your practice, right? And the things that you've learned and how to take all the information that you have, right? To be able to apply it and make decisions based off of that information. So I'm going to share my screen. I have the PowerPoints up for you. So critical thinking, the chapter in your book is chapter 5. I don't know if anybody has looked at the chapters or not. Um, but just an overview of critical thinking. Oops, let me move that a little bit bigger. All right, so some of the things that we think about when these are the top 10 reasons to improve thinking. Okay, so things are not what they used to be or what they will be in the changing healthcare system, right? The way I did things when I first became a nurse, right? A lot of those things have changed, and we know that healthcare is ever evolving and ever changing. LPNs frequently care for clients as a member of the healthcare team who are not yet stabilized and have multiple problems. And so, when we think of, working with stable patients, when would think of what's the word I'm looking for? An environment that you might take care of an unstable patient. Anybody have an idea? Where would you take care of an unstable patient?
In an emergency situation.
Okay, in an emergency situation, think of long-term care, right? Most of the staff in a long-term care facility are LPNs, right? And so are all of our patients stable all of the time? No, right? You never know what's going to happen in some cases. More clients and their families are involved in healthcare decisions. All right. So, people are also becoming more informed, right, about healthcare and their options. LPNs must be able to move from one healthcare setting to another, right? There's a variety of settings out there. We talked about some of them, right, where LPNs can work. And so you have that, go from one setting to another. A rapid change in information explosion requires LPN to develop new learning and workplace skills. A lot of what you learn a lot in nursing school. You learn a ton of information in nursing school. And when you get out into practice, you're going to learn even more, right? So, you're going to develop new learning, new workplace skills depending on and depending on the environment that you're working with, right, you're going to develop certain skills maybe a little bit more than others. Clients, families, and insurance companies demand to see evidence of benefits, efficiency, and results of care given, right? So we've seen a big push from quantity of care to quality of care, right? How happy is that patient or that client that we are taking care of, right? That's a big push to, trying to avoid those healthcare associated infections, right? The catheter associated urinary tract infections, the central line infections, the pressure areas, right? So we're looking at quality of care. Today's progress often creates new problems that cannot be solved by old ways of thinking. So like ethical and legal issues involved in end-of-life decisions, questions regarding stem cell research, determining who is entitled to receive expensive medical care. Redesigning care delivery and education programs is useless if students and nurses do not have the thinking skills required to deal with today's world. Learning how to improve your thinking skills does not have to be difficult. That is one thing that is very important to understand, right? It doesn't have to be a difficult process. And then your ability to focus your thinking on how to get the results you need can make the difference between whether you succeed or fail in the fast-paced healthcare system. As nurses, right, we are lifelong learners, right? Even though you may decide that you don't want to move on after getting your LPN, right? You may decide that you are completely comfortable being an LPN, don't want to go back to school. We always encourage it. It doesn't mean that you're going to stop learning, right? You are going to continue to learn. No matter what area of nursing you go into, you will continue to learn. Oops. Years ago, nurses saw themselves as doers, not thinkers, right? This was probably even back when I first became a nurse or when my mom became a nurse, right? We just waited for the doctor to kind of tell us what to do and we carried out their orders. But that things have changed, right? So as nurses, we have to be able to think critically. It is part of the process of nursing. And so when we look at the definition of applied critical thinking, um, so it's purposeful, it's informed, it's driven by family and client needs. It requires careful identification of problems, issues, risks involved, right? Whether, deciding whether a client needs one person assist or two-person assist to transfer them from a bed to a chair, right? Those are, part of what critical thinking is. It's driven by client, family, and community needs. So we have to be able to use that knowledge that we have to tailor our approaches based on the individual and the circumstances that we're working in. Critical thinking is also based on the principles of the nursing process as well as scientific methods. Making judgments based on evidence rather than just guesswork, right? And this is where I was saying when you go out into practice and there's a procedure that, this is the way that they do this procedure, and you do research and you realize that there is a better way to do that procedure, right? That is, something that we look into, we can bring to leadership to say, hey, this, evidence base says that, we can do this better this way. It uses logic and intuition based on your knowledge, your skills, and experiences that you'll gain. It is also guided by professional standards. So, think of NAPNES and the National Association of Licensed Practical Nurses, right? The Nursing Code of Ethics. And it calls for, constantly reevaluating and striving to improve. And that's kind of what I was saying earlier, right? What are things that we can do practice, depending on, where you work, like I said, you're going to hone in on some, certain specific skills and may, not use other skills, but practicing and attending classes, workshop, things like that. So I'm just going to use psych as an example, right? Nurses that work in psych, they may not use, skills like IV starts or blood draws or, inserting Foley catheters. I mean, it really kind of just depends on the, which area of psych that you're working in, right? But some of those hands-on skills, right, may not be there in psych. So keeping up, with your skills and practicing them, even learning new skills is going to be beneficial for you. So thinking is divided into non-focused thinking and directed thinking. And so non-focused thinking, you engaged your brain out of habit without much conscious thought. So just think of something that you would do that you don't really think about. Give me an example of a non-focused thinking.
Breathing.
Okay, breathing. Yeah, we don't think about it, right? It just kind of happens, right? Blinking your eyes. Okay, if you want to, those are your just
I was
normal
gonna say rolling your eyes sometimes.
rolling your rolling your eyes. Some of us do that without thinking that realizing that we're doing it. We also have habitual thinking, right? These are, getting up to go to the bathroom, shower, dressing, right? It involves any routine that we do that is important but doesn't require thinking hard, right? Getting up, taking a shower, doing your hair. Some of us don't do much to our hair, but putting your makeup on, right, doesn't require a whole lot of thinking, right? It's just kind of something that we do. Random thoughts are multiple short scenes and thoughts that come and go through the mind and have no particular purpose or goal, right? Mental channel surfing. Your ruminative thinking, the same situation or scene is replayed in the mind over and over without reaching an outcome, right? It's an instant replay. So this could be, you did something and, think about it and you're like, oh, I should have done it this way, or I should have said this. Ever get into an argument with somebody or a heated discussion with somebody, and after it's over, you sit back and you're like, oh, I should have said this, or I should have said that, or something along those lines, right? So that's your ruminative thinking. Your all or none thinking, the mind is made up and no additional facts will be considered, right? This is like things are black and white. There's no gray area in between, almost like a stubbornness, right? Negative thinking, the mind is stuck on negative thoughts and blocks worthwhile thinking. This is emotional sabotage, right? And a lot of times when we think about ourselves, right, we sometimes think that the negative is easier to believe, right, than the positive. What are some ways that we can get over negative thinking? What are some things that we can do to get over the negative thinking? It's a hard one, right? This one's a hard one.
Look at the situation differently. Try to
CBT.
put a positive spin on it.
Okay. What did you say, Sierra? I'm sorry.
CBT.
Okay, cognitive behavioral therapy. Right. What about self-affirmations?
Prayer.
Prayer. Right. All those are awesome. Good job. But I love self-affirmations. Just looking in the mirror and identifying what your positives are, right? Trying to get rid of that negative thinking. Directed or focused thinking is purposeful, it's outcome oriented. And then problem oriented thinking focuses on a particular problem to find a solution, right? And so this could be pretty much anything, right? Delegating tasks to your UAPs, asking for help. I know that's crazy, right? Also listening to input from others on situations, right? So and then we have our wonderful critical thinking. So critical thinking is an advanced way of thinking. It's a problem-solving method. Okay, so we use it to resolve problems, find ways to improve a situation, even when no problem exists. You're going to collect and analyze data to reach a decision. And so that's why I was saying it, it's going to answer those questions. How can we do this better? How can we assist our clients in achieving highest quality outcomes? What resources are essential? Which can be eliminated to save costs? These are all things that working in the healthcare field, you are going to, have these questions posed to you. And a lot of it too is how can we assist the clients in achieving highest quality outcomes? All right. So one of the big things in long-term care, and it's been evolving, over the years. And those of you that have worked in long-term care or have been in a long-term care setting for, your clinicals and things like that, right? They've taken away our side rails, right? We don't have a lot of things to help our patients to not fall or crawl out of bed and do things that they shouldn't do, right? And so it becomes, you kind of have to think outside the box, right? What are some ways that we can protect our patients without restraining them, without whether it's physical or chemical, right? Because we can't use restraints. So, that is, how do we achieve those high quality outcomes? What resources are essential? What are some things that we can do? Right. So that includes, what are some things that we can do to protect and provide that high quality care for our patients? And then you're looking at questioning with meanings. Critical thinking involves examining personal thinking as well as the thinking of others, and we make judgments based on facts, not assumptions. We avoid criticizing just for the sake of having our own way, right? And decisions are based on the right thing to do rather than emotions. And so a thinker, right, considers other ideas and recognizes that there may be more than one right way to do something. It's not my way or the highway. It's not, my way is the best way. What are some other, things that we can do? It realizes too that a perfect solution may not be possible. It also realizes that collaboration is a key to effective thinking as well as decision making, right? Get input from other members of the healthcare team. What are some things that we can do to make it better? And we use that nursing process or ADPI, assess, diagnose, right? Plan, intervene, and evaluate. And so, critical thinker pays attention to what the speaker is saying as well. So making sure that we understand what is being said, what it means, where does it fit into providing care. So when we, think about when you take your exams and your quizzes, right? That's critical thinking, right? You're taking the information that's being asked of you in those questions and you're, deciding on what answer. But when we look at critical thinking, right, it's just like I said, it's using that nursing process. You're collecting your data, you're verifying your data, you're arranging it, you're looking for gaps in information, you're analyzing, right? And then you're testing it out. What is working best for you? Other things that, we look at, Other questions, you know, what major outcomes do you expect to achieve? What problems, issues, risks should be addressed? What is the circumstance or the context, right? Where are you working? Are you in long-term care? Are you in home health? Are you in the emergency room? Are you in a psych facility, wherever, a doctor's office? And then, you know, how much time do you have? You know, think about that. If you're in an emergency situation, ABCs, right? You don't have as much time as you would have with a non-emergence issue. So these are all part of that critical thinking process. Factors that influence critical thinking: upbringing and culture. Why do you think upbringing and culture would affect your critical thinking?
How you view things.
Okay, how you view things. Absolutely.
Also how other patients are as far as like their views and their attitude and how they were brought up might determine how we take care of them medically.
Okay, very good. Very good. Um, and you know, culture, we already know, plays a huge part in healthcare. But even, you know, your upbringing and your client's upbringing, you know, was it a supportive education experience at home? And so were they able to develop their, you know, were you able to develop your reading and your comprehension skills as you grew? Motivation. So motivation is something that, you know, we have to look at, you know, what motivates us, our internal motivation, our external motivation. Why are you here doing what you are doing? What is your motivation for becoming a nurse? What's your motivation for becoming a nurse? Other than to help people, okay? What is your motivation for becoming a nurse? Why are you doing this?
I think it's kind of like what Joy mentioned last week, the joy of seeing the success. We had clinicals last week at the mental health facility in Orange Park, and there was a girl that was suicidal. And we sat down and we talked for a bit, and she, after a while, felt pretty good about things and ended up joining the rest of the group in their laughter and discussion instead of sitting there just looking really, really sad and kind of lifeless. So that was fulfilling to see that change.
Okay, so to see change, to see people get better, right? And yes, I know caring for people is, you know, a big motivator for a lot of us, right? Then why we do what we do, but caring for people, we need to have something that occurs, right? You know, we want to see positive changes, whether it's, you know, minor or major, right? Um, so, you know, if, you know, you have to take into consideration a lot of people go into nursing too because they know that, yes, they have the desire to be a nurse, right? But they also know that, you know, in 5 years, you know, they're going to have a job, right? There's always going to be a need for nurses, right? So it does provide some stability. And a lot of times that's a motivating factor for doing what we do. Attitude also influences critical thinking. All right. Critical thinkers are humble and recognize they don't have all the answers. They may be influenced by their beliefs as well as their values, right? When we're taking care of clients, it does make a critical difference whether a problem is recognized, missed, or ignored, right? So, when we look at attitude evaluation, you know, you know, I'm not going to ask you to do this, but there is an attitude evaluation in your book. And so it gives you a way to rate your attitude. We have to look at our personal, or we have to look at ourselves, right? In order to take care of our patients effectively, we have to understand ourselves as well. Um, and if you do your little attitude assessment, right, that also gives you an idea of some things that you need to work on, right? What are some things that I can improve, whether it's working with clients, whether it's working with other members of the healthcare team, right? And we can, kind of work on that from there. Other additional factors that affect critical thinking, effective reading. Reading is, it's more than just reading a paragraph or reading an article, right? Are we understanding what is being read? Are we able to evaluate it and then put it into practice? It also means that you can identify the significance and potential application of what you're reading. Um, Maturity. A lot of times maturity comes with age, right? As you get old, you're supposed to get more mature, but age does not necessarily determine your maturity, right? I've met very, young students, 18, 19, that are very mature, and I've met older students that are not as mature, right? So maturity doesn't necessarily come with age. But maturity does allow us to take our past opportunities that we've worked through situations or we've worked through problems. And becoming more mature, it also helps to see problems through someone else's eyes. With problem solving, or I'm sorry, yeah, problem solving and the nursing process, knowledge of problem solving and the nursing process is based on a lot of the same principles as critical thinking is. I used to tell like newer, students that were in the beginning of the program learning about the nursing process, in order, just to practice using the nursing process, you can apply that to anything. It doesn't have to be a client issue or a patient issue, right? I used to tell them, use the process to, make a peanut butter and jelly sandwich, right? And that just kind of helps you work through and understand how the process works. The better you understand the process, right, the better that you can work through things. Communication skills. We've talked a lot about communication, and we know how important it is to communicate effectively, right? Whether it's using our verbal skills, our nonverbal skills, our writing skills. Also, are you willing to listen and consider ideas that are different from your own? Some people express themselves better verbally than they do in writing. All right. And so we know as nurses, we need to develop both skills, both verbal as well as writing, right? Because we're going to write a lot in nurses' notes. I will be the first one. Like, I dislike writing nurses' notes. Um, a lot of times too, when we're writing on, with nursing notes, if it's not like an unstable situation or an emergency situation, right? We're just writing a generalized note. You're like, I don't even know what to write. What should I say? Um, and sometimes even for me, it'll take me, a few minutes to sit there and gather my thoughts, and I will write and rewrite until I get, exactly what I want to say and make it sound, like it makes sense. Um, Self-confidence. Self-confidence. How many of y'all, I mean, and you don't have to answer me out loud. You can if you want to, but how many are pretty self-confident with themselves, with their skills, with their ability to communicate? Okay, awesome. How confident are you guys ready to go out into the world of nursing?
I'm about 85% confident.
All right, 85% confident. That's awesome. Um, when we look at nursing school, and I think from day one, nursing students are like, can't wait for this to be over. Is it over yet? Right? And it seems like we're counting down the days from day one. But then when we start to get towards the end, we start to get a little bit nervous, right? Because now what? Right? You don't have the protection of school anymore. You're going to go out into the great big world of nursing. Um, no one can give you self-confidence, right? You develop self-confidence as you succeed, right? You pass the quiz, you pass the test, you pass the class, right? That should help to build your self-confidence, right? Um, on the opposite side of that too, overconfidence can make people assume they are correct even before data is available to back that up, right? So we have to, it's great to be self-confident, but we have to make sure that we, don't go into the opposite end and become too overly confident. Moral development. So moral development, that's your fair-mindedness, a strong sense of what is right, what is wrong, and what is just, right? So again, this is about a self-reflection. What are, your core values? What is, what do you feel is right? What do you feel is wrong? Right? Do they align, are they going to always align with the clients that we're taking care of? Your capability in nursing. Capability in nursing is absolutely essential. You have to have nursing knowledge and you have to have the skills in order to do nursing, a nursing job, right? You also have to know what resources are available to you. And again, in nursing school, we are going to, we strive to teach you and show you as much as possible, right? And we're not going, there's no way to teach you absolutely everything that you'll ever need to know about nursing. And that's why nurses are lifelong learners. You're going to continue to learn. And so, we try to teach you what we think is important, to move forward with, as you go out there into the world of nursing. Collaboration is another thing. Collaborative, I mean, you have to be able to collaborate with other members of the healthcare team. Collaboration also helps to promote critical thinking skills. So like some schools that have, I just thought this was interesting and I did research on this. Some schools that have multiple programs, kind of like Fortis has, dental assisting, they have medical assisting, trying to think of what else. They have a variety of other programs, right? And some schools also will collaborate amongst the different programs, right? So, what does a medical assistant do, right? What is their job description? What does a pharmacy, what is it? A med tech, right? What does a med tech do? What's their scope of practice? What is their role, right? So when we look at the interprofessional, it just kind of helps you learn how to work with other disciplines and understand what their scope of practice is. I've never worked with med techs before until I moved to Texas. Um, and so I know that there were med techs in Virginia, but I never worked with med tech. And so now down here, med techs will pass medications, right? And so then that leaves the nurses to kind of take care of everything else. So it is kind of an interesting process. And so again, understanding and working with members of the other, of the healthcare team is going to, right, be super important. Anxiety. So anxiety, low levels of anxiety, even up to moderate levels of anxiety, right, kind of increase our awareness, right, increase the ability for us to retain information. But when we get to those higher levels of anxiety and when anxiety overwhelms us, it stops our critical thinking process. All right. Same thing with a high level of fatigue. If you're extremely tired and you're not getting enough rest, all right, that is also going to impede your critical thinking skills. One of the best pieces of advice that I had got when I was in nursing school was from an anatomy and physiology teacher, who told us if you have the choice between study and sleeping, he said, always choose sleeping. He says, because a well-rested brain is going to work better than a tired brain. And so in some cases that was true. Other cases, sometimes I was like still going to spend, the night studying. But this is where coping skills come into play. How many of you work well in high stress situations, right? If the world is crumbling down around you, you can maintain yourself and maintain cool, calm, and collected. Awesome. Okay. So you never know what you're going to experience, right? You may go, one day the unit's calm or the emergency room's not that busy, right? And then the next day you come in and it looks like a battlefield, right? And everything seems to be going wrong. And not everybody can deal with high stress situations, right? And so, finding ways to decrease your anxiety, to remain calm, also helps to bring calmness, right, to others around you. And then mentors and experience in nursing. So work experience, guidance via mentors, help you to learn as well as identify priorities in nursing care. How many of you are in a preceptorship right now? Is anybody are you guys just doing clinicals? Okay. Um, so, mentors or preceptors can be very valuable, as can your nursing instructors, right? Um, and when you got out into practice, hopefully you will find a mentor that you can really lean on and depend on to, help you adjust, right, from student to nurse.
I have a question regarding that.
Uh-huh.
Because I ran into an RN who's on the force for like 25 years, and she said, it's cool to reach out to her because I told her I did need a mentor, going forward. What would be some, like, I don't know, I guess good questions or like topics to get into with her as like a new grad LPN?
Um, Time management, right? Depends on the area, right? So what area does she work in and what area do you work in? Are you going to work in? Is it going to be the same?
That I don't know yet. I honestly don't. So that's a good point.
Yeah, but they can, it's always good to have someone that you can reach out to say, this is the situation, right? And use your S bar, okay? So, say her name is Mary Jane, okay? And be like, hey, Mary Jane, all right, this is my situation, this is my background, this is my assessment. I'm working on my recommendation. I would recommend blah, A, B, and C. And then, that would be something that she could come back and say, okay, you did this really well, you did this really well, you're missing this, right? Those types of things, right? That will help to kind of get you into a flow. So I will just
Uh,
give you like an example. I worked with a new nurse last night. She's been an RN for, I want to say like 3 or 4 months now, so it's not been a really long time. We had to send a resident to the emergency room, okay? And so, she's like, I don't know what to do. And I'm like, okay, let's just take a deep breath. And so I said, well, first, let's do our assessment. Okay. And then let's call the provider. And she was like, okay. So she runs in the room, she comes out the room and she's getting ready to call the provider. I said, do you have vital signs? And she just looked at me. And I was like, okay, let's go get vital signs, right? Let's start from the basics, right? And so I walked through the process. And so, it was, just needed to kind of take a step back and slow down. Yes, was it an urgent situation? It absolutely was. Was it emergent? No. It was unfortunate. This resident had COVID pneumonia. We had treated the pneumonia and everything like that, but her lungs were just, still really bad. But yeah, just someone that it doesn't have to be anything specific, Stefania. Like it can be just kind of like, what can I expect? It could be understanding processes, it could be understanding, like situations like that. What do I do? How do I work those out? And just start with those basics, right? And she was like, I didn't even think to get vital signs. And I'm like, it's okay. That's why we have to take a step back, right? And just remember like nursing skills, like what's the information that we need to present to the doctor? And a lot of people are terrified to call the doctors. Has anybody had to call a doctor yet? Okay. A lot of people are terrified to call providers, right? And so I was my first time calling the healthcare provider. I did the same thing. I completely forgot to get vital signs. And that was the first question he asked me, what are the patient's vitals? And I went, I forgot to get them. And he hung up on me. He was like, get her vitals and call me back and click. And I was like, oh, so sometimes it's just, things like that. It can just be, like I said, it can be a case by case basis. But if you're working in the same area, she might be able to provide even more guidance as to like what specific area that you're in.
Thank
When we
you.
look at critical thinking and NCLEX cognitive levels, and so you've seen these levels when you've done your NCLEX, your NCLEX questions. The knowledge is, recall, right? You memorized, the information, you can recall it. But remember though, memorizing is not always understanding, right? That's something is completely different. But knowledge is our lowest level, okay? And so when we look at, you're getting ready to, pass your NCLEX, right? There may be some knowledge questions on there. There may not be, right? They're starting to look more at those higher level questions. Comprehension is the basic understanding. You can recall it. You can identify examples of that information. But it is also the lowest level of understanding. Application. This is applying what you have learned to new situations. Whatever, things that you learn in class, you may be able to apply in clinical, even vice versa. It also helps, it's also being able to prioritize or determine what is more important, what comes first. This is a higher level of understanding. And so in order to apply, you must be able to, you have to have the knowledge, right? So that you can apply that knowledge to what the situation is. Analysis is breaking down complex information into basic parts and then relating those parts to a big picture. Organization, prioritizing, those are part of an analysis. It's also a higher level of application. So when you've done your NCLEX questions, and I've, told you to remediate on those weaker areas, a lot of it is analyzing and applying, right? That people have to work on. And that's okay. This is your time to work on those informations. You need to be able to identify the most important symptoms, right? And what are you going to do, right? Comprehension application analysis. Those are what employers are expecting of LPNs when you start to, work in the healthcare field. Instructors also expect this level of competence in the clinical area as you prepare for your transition from student to nurse. And the LPN is responsible for many of the judgments and decisions made in healthcare. Think of the clients that you're working at, you're working with, and the areas of practice. And as a newly licensed LPN, you are going to be required to make more complex decisions about clients. There's a nursing shortage out there, right? And nurses are needed to go out and just jump into practice. All right. So let's do this. All right. So Jane Harris, aged 58. She weighs 92 kilograms. She's 162 centimeters tall. She has a BMI of 35.1. Her chief complaint is, I've been feeling very tired, thirsty, and I go to the bathroom a lot. What are those 3 symptoms indicative of? I'm tired, thirsty, and I go to the bathroom a lot.
Diabetes.
All right. She has a medical history of hypertension and a family history of diabetes. She's on lisinopril 10 milligrams per day. Her vital signs 98.6, 88, 146 over 90, 18 respirations, SpO2 of 98% on room air. Here are her labs. All right, so her fasting glucose is 178. Look at that hemoglobin A1C, 8.2. Cholesterol is 210, LDL is 130, HDL 38, triglycerides 220. What is she? What medication? She's on lisinopril. Looks like she probably needs to be on a statin too, right? Oops. Come on. Creatinine 0.9, GFR 88, and albumin, urine microalbumin 40. All right. So what are the diagnostic? You don't have to yell them out, but remember what the diagnostic criteria is for your diabetes mellitus. Based on her labs and symptoms, why is Miss Harris likely a diabetic? So based on labs and symptoms, right? What do we look at? So we saw her fasting glucose, right, was 178. Her hemoglobin A1C is 8.2, right? So those are pretty indicative that she has diabetes. What initial management steps would you implement for Miss Harris? And then identify possible complications of unmanaged diabetes in Miss Harris and assess the appropriateness of her current antihypertensive regimen. All right, so fasting glucose, or the fasting plasma glucose greater than 126 milligrams per deciliter with a hemoglobin A1C greater than 6.5, right? So those here are your indicators for the diagnosis of diabetes. She does have the classic symptoms, right? The only one is missing. Which one is missing? What's the third P?
Polyphagia.
Thank you. Yes. And she had that the fasting glucose of 178, the hemoglobin A1C of 8.2. So lifestyle changes are always going to be the first things that we teach our diabetics, right? Diet, exercise. We also have to address her high lipid levels. So we could do lots of education for her, right? So think about, not only just for the diabetes, right, but for her hypertension, right? And we can look at diet, the DASH diet. We can, also look at different diet, for the high lipid levels. She will probably end up on a statin, right, to help bring those lipid levels down. And then we want to try to, the research says the tighter glucose control we have, right, the more likely we will be able to maybe not prevent totally, right, but decrease the chances of the micro and macrovascular complications associated with diabetes. All right. So that brings us to more about healthcare systems and healthcare settings. So we're going to start with healthcare settings. Let's go ahead and take a break. We'll just do a quick one. Be back at 4. All right, so let's talk about some healthcare settings. So this table is in your chart. This is a comparison of healthcare agencies, public versus private. So when we look at public, we have official, which is our government, and we have non-official, which is voluntary. And so when we look at support, so official or government is supported by tax money. Non-official or voluntary are supported by contributions and fees for service. The primary services of government would be disease prevention, wellness promotion. Your non-official, you see, oh, I forgot, I'm not sharing my screen. I apologize. My brain. All right, so here we go. So then again, primary service for official or government programs of disease prevention, wellness promotion, your voluntary research and education, additional services. They sometimes will direct services of healthcare. Non-official or voluntary will offer direct health services. Accountability of government, right? It's going to be towards the taxpayers and the government as well. The accountability for your non-official would be the supporters, the boards of directors, things like that. And then how the programs are determined. Public have mandated and non-mandated programs. And public will have, or the non-official have supporter interest. And we'll talk about mandated and non-mandated. And then your private hospitals, primarily their support is fee for service, right? You go to the hospital, right? You go to the emergency room, and there's a fee that needs to be paid, and that is how they support their hospital system. Their primary services are curing disease and illness, right? You go into the emergency room for whatever reason, you get admitted, right? They're there to treat and cure you. They also will focus on disease prevention as well as wellness promotion, and their accountability is to their owners. So I don't know if anybody knows of any private hospitals, within their areas, but their primary accountability is going to be to their owners. And that determines, the programs are defined goals of the organization. And we'll talk more about it, but so again, this is kind of more if you're a government, again, they're nonprofit. Your voluntary can also be nonprofit as well. But they'll, also participate in research and education. So public healthcare agencies. So there's two types of public healthcare agencies. Again, there's, we have official and voluntary. The official health agency at the local level is your city or county health department. And they are funded by local tax money as well as subsidies from the state and federal levels of government. They carry out state mandated laws concerning community health. They also carry out non-mandated programs like health promotion and programs. They collaborate with other government agencies and respond to community health issues, right? Outbreaks or contagious disease. So, everybody has a local health department, whether it's actually local to them or within their area. And these are just, if you remember from community, these are some of the things that your health department is going to do. Each state has a state health department that is funded by tax money. Again, they also may receive subsidies from the federal government. Your Department of Health and Human Services has a bunch of other divisions that fall under them. And then there's another group that fall under the US Public Health Services. So some of them, these are some of the ones that most people recognize, right? The US Food and Drug Administration, right? So the FDA ensures that food, human and animal medications, biologic products, and medical devices and electronic products that emit radiation are safe and, if applicable, effective. Your Centers for Disease Control and Prevention provides leadership in health prevention and promotion programs. It also responds to public health emergencies. The National Institute of Health funds biomedical research in its own labs, as well as other universities, hospitals, private research institutions, and the private industry. The National Institute of Health also trains new researchers and promotes collecting and sharing of medical knowledge. And there's 27 institutes and centers, including the National Institute of Nursing Research. We also have voluntary non-official healthcare agencies. And a lot of us have heard of these as well, right? These are like your American Cancer Society, the American Diabetes Association, American Lung, American Heart Association, American Stroke Association, Alcoholics Anonymous, La Leche League. There's also like Easter Seals and Narcotics Anonymous. So there's a variety of different, also non-official healthcare agencies out there. So we get back to the private healthcare agencies are either for-profit or nonprofit, right? So they either are for-profit or nonprofit. They also have, the fee for services. The goal there is to cure disease and illness with a recent emphasis on disease prevention and wellness. Most people get their healthcare through private providers. Think about, your your primary care providers, the hospitals, right? The clinics that you go to. Family practice physicians deliver primary care and refer to specialists if additional evaluation is needed, right? So they're the ones that kind of keep track of your health care, right? So you go to your doctor because your knee hurts, right? They may send you to an orthopedist, right? But they're still going to, and then that orthopedist is going to send that information back to your primary care. So they kind of are the central part for you to kind of coordinate all your other care. Private practice nurses are advanced practice nurses who counsel individuals on healthcare issues. They fill an acute need in rural areas where physicians are sometimes difficult to obtain. I'm sorry, I don't know why, but my dogs are like going insane, so I apologize. When we look at the different types of hospitals, so we have community, we have federal, and we have non-federal psychiatric. All right, so general, they provide a diverse range of medical services. They may not have specialists to treat serious conditions. Right, go to the emergency room, they may not have somebody there specifically to treat your condition, right? So we may have to, refer to a different provider outside or call a different provider in. Your specialties, services offered related to a particular disease. They have highly skilled specialists with advanced knowledge. So I don't know if anybody has any like specialty hospitals that are in their area that focus on specific things. I'll never forget my mom's first job out of nursing school. She worked at a specialty hospital. It was also a cancer research hospital. And my mom's biggest fear out of nursing school was trach care. She was terrified of doing trach care because she was always afraid that she was going to suffocate the patient. And the first unit that she worked on was a trach unit. So every single one of the patients that she took care of had trach. And so she became very comfortable with trach care after that, right? But you may have certain hospitals that are, geared toward particular diseases, or certain services that are geared toward particular diseases. Voluntary community hospitals, they are like community associations or religious organizations. Anybody think of a voluntary community hospital that is affiliated with a religious organization? You see the commercials all the time.
St. Jude's.
Yeah, St. Jude's Children's. You also have the Shriners Hospital as well, right? So those would be more, based off of religious organizations. They provide short-term inpatient care for people with acute illnesses and injuries. There's also Bon Secours. I don't know. I think it has a different name now. It is also religious affiliated. But they are heavily dependent on gifts and donations to supplement the source of revenue, right? So that's why you see like they have the St. Jude's marathons and the other types of, fundraisers, same thing with Shriners, right? And the Board of Trustees appoints a paid administrator to manage that hospital. Your federal or state government, which are your public hospitals, they're things like your Veterans Administration, your state, county, and municipally owned and operated nonprofit hospitals. These are hospitals for people with serious mental illness that are funded by federal, state, or county funds. We have teaching and research hospitals. So both community hospitals and federal government hospitals can be teaching and research hospitals. It is, they often will have, training sites for healthcare professional as well. They do still treat clients, especially those with serious or unusual conditions. They conduct research and development of treatments. They also will do clinical trials. They are almost always associated with medical schools and people there. They have access to highly skilled practitioners. So just for example, I know in Virginia, we have Eastern Virginia Medical School, which is on the same campus as our Children's Hospital and one of the large Centera hospitals, right? And all three of them kind of work together. They do a lot of research. They do a lot of development of treatments and things like that across the lifespan. Your critical access hospitals, these have no more than 25 inpatient beds. The average length of stay is no more than 96 hours for acute inpatient care, offering 24 7-hour and 7-day-a-week emergency care. They're usually in rural areas, pretty far from other hospitals. We also have ambulatory services. And so there's a variety of different ambulatory type services out there. Your outpatients, your healthcare providers, your freestanding ambulatory centers, your urgent care centers. They are located in private and public sectors. They generally are less expensive. And these are for people who live independently or are cared for at home. They provide assessment, treatment, as well as care coordination. Your public ambulatory health settings, that could be like your community health clinics, your Indian health services, your community and your migrant worker health centers. Outpatient clinics provide follow-up care to clients after hospitalization. They can manage diseases on an ambulatory basis for those who do not need to be hospitalized. They can either be part of a healthcare facility or they could be freestanding, so not attached to a hospital. Usually we'll need an appointment But it does include specialty areas like your diabetes, your neurology, allergy, oncology. And the number of specialized clinics are going to depend on the population of the area as well as the needs of the population. And then you have your urgent care centers, which there's a variety. Oh my gosh, there's so many different types of urgent care centers. These are generally services for walk-in clients, for a lot of patients, especially those that may be underinsured or uninsured or don't have a primary care provider. They often replace healthcare providers' offices. So they make primary care available as an alternative to family healthcare providers. Like I said, they used by people who don't have a family physician. And the name reflects the type of care provided. So express care, quick care, urgent care, convenience clinics. I've never seen a convenient clinics. I've always seen like express care or urgent care. Your surgical care centers or your ambulatory surgery centers, they perform surgeries. You need to have a surgery done. You're going to schedule, they schedule your time and date. And then once you recover from anesthesia and you're stable, right, you go home. And so what's nice about your 1-day surgery or your ambulatory care or your ambulatory surgery centers, it eliminates the need and monetary charges for being hospitalized overnight because not everybody has surgery and needs to spend the night, right? Services are also known as outpatient surgery. They could be within a hospital. So, the local hospital may actually have an outpatient surgery center as well. It's the same concept. You go in for pre-op, you have your surgery, and then once you're stable and you recover from anesthesia, you go home. Most of the time, these are not going to be for complex surgeries, right? These are like more of your minor surgeries. Usually if it's a complex surgical procedure, right, they may have to have their surgery in an inpatient setting. We also have free clinics, and free clinics are usually, it's an alternative means of providing primary care. People who can't afford traditional health services or are reluctant to use more traditional services can use the free clinics. Cost is based on income. They generally will have an age or an income limit, and it's staffed by salaried administrator and then volunteer healthcare providers, right? So most of your providers and your healthcare providers, your nurses that work in the free clinics are doing this on a voluntary basis. And then you have a board of volunteers that make the policy decisions for the clinic. Alternatives to long-term care or, long-term, we'll start with long-term care. So skilled nursing care. These are long-term care facilities that are designed to help people who have disabilities or chronic medical needs. Skilled care is considered care that is medically necessary to improve the quality of the client's health or to maintain or slow decompensation of a client's condition, right? So let's say you have a patient that had a hip replacement, had a knee replacement, had another type of surgery, and they need skilled services, whether it's PT, OT, speech therapy, because, we deal with a lot of stroke patients as well. They need strengthening or they need to learn how to perform ADLs, right? They'll go into a skilled nursing facility to get that. And it's so interesting now because when I first started in skilled care, the average length of stay was 100 days. They would come in and they would, get their therapies and recover, and they were there for an average of 90 days. Now the average is less than 30 days. And that has a lot to do with just the advances in medical care. So for example, I'm going to use a hip replacement. Back when I first started nursing, hip replacements, you were literally non-ambulatory for 6 weeks. Okay, plain and simple. You were non-weight bearing for 6 weeks. And then after the 6 weeks, you would start, the actual physical therapy. They would still do like range of motion and maybe some, slight things just to kind of try to maintain muscle tone. But a lot of times it was 6 weeks. Now people have hip replacements and they're up walking the next day, right? So they've made a lot of advances, and same thing with knees. I remember with knee replacements and things like that, they would come in, they would be, non-weight bearing for 6 weeks. We'd have to use, I forget what it's called. Oh, my brain just went blank. The passive range of motion machine for the knees. We'd have to hook them up a couple times a day. Now it's the same thing, right? They're up, they're walking the next day. So things have changed. The length of stay has definitely decreased. Stroke patients, it depends on the level of disability and what their needs are. So their stay may be a little bit longer. When we look at alternatives to long-term care facilities, home health. So home health agencies are either public or private agencies that provide home health services in the client's home. And so there's also public and nonprofit. There's private nonprofit, there's private for-profit home health care agencies. It really just kind of depends on the location. But the services that are provided are skilled services. So skilled nursing, physical therapy, occupational therapy, speech therapy. They also have access to social services. They also may have like a home health aide that comes in, helps with cleaning, cooking, that kind of thing. And they depends too on the client situation. They may also require like respiratory therapy, podiatry, nutritional services can also be offered within the home. Your skilled care nursing or skilled nursing services are provided and directed by RNs. And then the basic nursing care, right, is going to be provided by the LPN under the supervision of the RN. And so then, of course, they also may have CNAs that come out and assist as well. Sorry, I didn't advance. But some of the other services, right? Teaching, supervising, administering or preparing medications for self-administration, giving injections, glucose testing, ostomy care, wound care, bowel and bladder retraining, oxygen and respiratory care are all example, things that LPNs can do under the supervision of the RN. And then other types of care, we have community health nursing services. Then remember back in community, right? The goal is to improve the health status of communities or groups through education, screening, and care outside of the acute care setting. The community health nurses work with, people and groups on prevention and modification of health issues. Adult daycare centers. These are either they can be hospital based, but they're also freestanding. They provide services for individuals who need supervision because of physical or safety needs, but are not candidates for a long-term care facility, right? So these are really good programs. It's like your PACE program. It's associated with some hospitals. But a lot of times they get picked up in the morning, and it helps, it provides mental stimulation, socialization. They also provide assistance with some ADLs. They're in a nice, safe environment where they're being observed. They'll, again, they usually have transportation, they'll have meals. They also may have some activities, therapeutic activities that go on, rehab activities. They also may have access to healthcare providers depending on the type of adult daycare center it is. But these are great, think about some of your elderly people that live at home by themselves. Yes, they still may be able to take care for themselves, but how often do they get out and socialize? And we know how important that is. So adult daycare centers are really, really, they're beneficial to a lot of people. Independent living apartments, they're not licensed, they're not regulated for healthcare delivery. They do have, some services that are available, like planned activities, they may have bus trips and things like that. And it's like an independent living apartment. Um, a lot, some communities now, when we look at like long-term care, I know a couple of them, they have like an all-in-one. So they may have like one area that's an independent living, and then they'll have like an assisted living area, and then they'll have like a skilled care, long-term care. So like say like they, the patient starts in the independent living, maybe their health starts to decline, they can go down to assisted living, or something like they fall and they break a hip or something, have a stroke or heart attack or something like that, then they can go to the skilled care, right? So they have all levels of care, maybe within the same grounds, maybe not in the same area, but in the same, they may have separate buildings, things like that. And so it's a nice, kind of area where they, aren't disrupted a lot. They're just going from one area to the next. Assisted living programs provide services. They have their own living areas. Generally, it's just people that need help with their ADLs. They usually have private rooms and bathrooms. They're always going to be handicapped accessible, and they will have help with their daily routine, like bathing, dressing, that kind of thing. And the continuum there, so the continuing care retirement community, that's the one I was talking about, where they have anywhere from skilled nursing care to independent living. Rehab services focus on return of function and prevention of further disability. And we talked about this. This is like your PT or OT or speech therapy. And that can be provided in long-term care facilities, rehab centers, outpatient facilities, residential homes, client space, client's home. They also have, what is it called? More of acute rehab services or more intense rehab services. More like a specialty hospital. So depending on, if it's the patient had a stroke, and, we know that with strokes, right, the quicker that we get their rehab started, the more intense the rehab is, the more likely the more better the outcome. So I always refer to them as specialty hospitals. I'm not quite sure, or acute rehabs. They just provide a more intense rehab than a skilled nursing facility would provide. Wellness centers, they promote wellness, and detect diseases in the early stages. Not all hospitals have developed programs for this, but some of the services that provided by wellness services would be your nutritional counseling, exercise programs, stress reduction, weight control. This is, like even some insurance companies now, especially for the older population. I don't know about the younger population, but like the older population too, like through Medicare, I think it's through Medicare, like they can get access to like a fitness center or a gym or something like that to increase to get them to exercise, that kind of thing. And then we have our hospice. So hospice or our end of life services, um, this is available in most areas. It's for people that have been certified as terminally ill. In order to qualify for hospice, there needs to be a diagnosis, and it is usually they have 6 months or less to live. And that's if the disease runs its normal course. Not everybody is going to pass in 6 months, but the general prognosis is that it's 6 months or less. And the philosophy is of hospice is to maintain comfort as death approaches. A lot of your hospice agencies have a philosophy, their philosophy is death with dignity. And hospice can be offered pretty much anywhere. Long-term care facilities, skilled care facilities, hospitals, and patients' homes. There are also hospice houses that people can go to. Biggest thing is pain and symptom management with hospice, right? We want them to be comfortable. And then your palliative care provides comfort care, which is similar to hospice. However, with palliative care, it's initiated at the onset of treatment and can be accessed at any stage of illness, whether they're terminal or not. And so the difference here with palliative care, they can choose life-saving implementations, whereas with hospice care, we've stopped life-saving treatments. Not all palliative care is hospice, but hospice clients receive palliative care as well, right? So palliative care, if you think about it, right, we're just trying to keep them comfortable and safe, but we'll still provide curative treatment. Whereas hospice, we're providing the palliative care, but we're not going to provide the life-saving treatment that you would see with palliative care. All right. And then we have our last one. And so this one, this is about who pays for healthcare. So we're going to talk about Medicare and Medicaid and different types of insurances. So just, yeah, there's a little bit more knowledge based, just like the previous chapter, is kind of understanding like the different, types of care received. And now we're going to talk about how to pay for it. So, so the US healthcare system has been described, go figure, as a poorly organized and complicated maze of services which lacks preventive care, waste resources, and is very expensive. Right? Anybody disagree with that? So we know that the healthcare system in the United States is a little bit of a mess. We know it's very expensive. And so Medicare, Medicare changed from fee for service to prospective payment based on DRGs, and then other healthcare services insurances followed. So what does that mean? So fee for service. You go into the emergency room, you go into the doctor's office. Let's say you cut your finger on a can, all right, and you need stitches. All right, so fee for service is, right, you're going to pay for the provider, you're going to pay for the stitches, right, whatever the service was that they provided. Diagnostic related groups are, it's like a lump sum kind of fee. Okay. So let's say we have a client that comes into the emergency room and they had a heart attack. Okay. There's going to be our DRG for heart attack. This isn't like exact. Okay. I'm just trying to use an example. All right. And so there's going to be a flat rate for a client that has a heart attack. All right. So that is basically what a DRG is. Same thing for stroke, all of that. So when we switched to the DRG, because we're getting a standard amount of money for that disease process, the healthcare team was focused more on minimizing the length of stay, right? Because the shorter the stay, the more apt the hospital is going to make money, right? So wasn't it's an interesting process. We still use DRGs, okay? And then we eventually evolved. And so the payment system extended to include healthcare provider payment, which led to the birth of our managed care organizations. So who has a private health insurance, whether it's through their job, their spouse? Who's got health insurance? Nobody has health insurance. We have a couple people that have health insurance. Okay. So your health insurance,
Private insurance is just not private.
okay. Military.
Medicaid, babe.
Okay. Well, we're going to talk about that too, because that's going to fall under here as well. So managed care organizations, these are things like your HMOs, which are your health maintenance organizations, your PPOs, which are preferred provider organizations, point of service plans, and then we have open access plans. So there's a variety, oh, my apologies. There's a variety of different managed care organizations out there that people can, choose. Even with all the changes that they've made, there was only a small improvement in healthcare costs. And we know that the costs of healthcare continue to rise. We know that there is inequity among, the inequities in healthcare access in the United States. Not all Americans had access to healthcare, and that, we did have the Affordable Care Act, which the goal of the Affordable Care Act, right, was to increase the number of people in the United States that had access to, healthcare. And it made a huge change. We still have plenty of people here in the United States that don't have health insurance, that are underinsured, and that don't have access. So with that Affordable Care Act, right? Again, it enhanced the access and affordability of healthcare, particular to all citizens in financial need. It established the health insurance marketplace. And the health insurance marketplace is a resource for whether you're by yourself or you have a family or even small businesses that can learn about their healthcare options, choose a plan and enroll in coverage. It also provides information for people with low to moderate income and resources, right? How to pay for those services. So it has decreased the number of Americans without health insurance, right? We still do have quite a few that don't. A nice thing about the Affordable Care Act, it also reduced prescription drug costs for Medicare beneficiaries. And it allowed for pre-existing conditions to be covered. And that's always been a topic of conversation. So let's say you are diabetic, or you have kidney disease, or you have, another chronic condition, even switching jobs, or, losing your insurance and trying to find another one. A lot of times they would there would be a period of time where you wouldn't get coverage for any pre-existing conditions. So it did get rid of that issue as well. Because imagine you're a diabetic and, you decide that you want a different job because, pays more, it's got better benefits. And then you have to worry about your, the care that you need for your diabetes being covered by your new insurance company. All right. So when we look, I'm trying to make sure. So I want to go into some basic terms before we go into the different types of insurance and things. So health insurance terms, we have a premium. All right. So a premium is the monthly fee you pay for your health insurance coverage, right? So you get a job or you get, insurance through the Affordable Care Act, where however you get it, right? And they tell you what your premium is. All right. So let's, so you have to pay, $500 a month to have your health insurance. Okay. And that's a set fee that you're going to pay. Your deductible is the amount that you spend out of pocket for services before a health insurance policy will begin to pay its share. So for those of you that don't have insurance or have never had to choose insurance, a lot of times when you start a new job, you're going to get a couple different options. All right. So these are some of the things that you need to look at when you're doing it. So again, the premium is how much you pay for your insurance. Your deductible. Some deductibles are really high, some are really low. Let's just say you have a really high deductible, like $2,000. All right. That means that you are going to pay out of pocket $2,000. Once you get over $2,000, then your insurance will pay the rest. All right. So if you're someone that doesn't go to the doctor very often, right, you never, may never pay the $2,000, but that is something to be, to think about. Your copayment is how much you pay at the time of visit, when you go to pick up your prescriptions at the doctor's office, or you have to go to the emergency room. The copayments are different for each type of service. So you may have one copayment for your primary care. There may be a separate copayment, a higher amount for specialty care, and then hospital may be a little bit higher as well. Coinsurance, once your deductible is met, the percentage of the bill that you must pay, and then the insurance company pays the remainder. So you've met your deductible and you go, there's not every insurance has a coinsurance, some do. And then, this is how much that your insurance is going to pay. This is how much you have to pay. So those are things to when you're searching for your health insurance, when you get a job, or if you have to switch insurance for whatever reason, those are things that you want to pay attention to. So how we pay for services, again, some people pay privately, they pay out of pocket for their healthcare, the healthcare services because, they don't have insurance. But now we have so many different types out there. So we have private health insurance. And again, the Affordable Care Act prohibits discriminating against people with pre-existing conditions. Insurance companies are prohibited from refusing coverage to anyone based on medical history or health status. It also prohibits individual and group health plans from placing lifetime limits on the dollar value of coverage, and prohibits insurance companies from rescinding coverage. All right. So, they can't, you're, diagnosed with cancer and you have to go on chemotherapy, right? They can't pull your coverage because of that. So your private group health insurance, this pulls individual contributions for a common group goal. So they, before the Affordable Care Act, again, a lot of people couldn't afford health care and, health insurance or at all. But this employers offer most of the private group insurance. So like, you go to work, you get, they may offer Blue Cross Blue Shield, United Healthcare. Trying to think, I don't really know anymore. Aetna. It just really depends. A lot of times depending on where you work, they may have different options for you. Some maybe, cost a little bit more, some may cost a little bit less. The American Care Act does not require all employers to provide health benefits. However, it does impose penalties on larger employees or employers that do not provide insurance to their workers or that provide coverage that is unaffordable. And then smaller businesses, if they do offer health insurance, they get a tax credit. But like those usually they're smaller companies or less than 50 people. So they don't have to offer insurance, but if they do, they get a tax credit. Your private individual health insurance, those are offered by insurance companies to individuals who are not part of a group. So let's say you maybe you work for yourself or you have your own business and you need to have health insurance, right? You can go and look into the non-group health insurance. The premiums are based on age and tobacco usage with the private health insurance. And some, Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, they all may offer non-group health insurance as well. I already talked about those. And then we have our public health insurance. So we have the Veterans Health Administration. They provide comprehensive healthcare services to veterans. And so they have hospitals, they have outpatient clinics, they actually have nursing homes, domiciliaries. I'm trying to think. They have pharmacies. They provide pretty much every specialty to the veterans. And then we have Medicare. So Medicare is, keep forgetting to switch the slide. I apologize. So Medicare is federally sponsored entitlement program and public health insurance plan for persons over the age of 65 that have paid at least 10 years into the Medicare program. All right. So in order to be eligible to get Medicare, when you turn 65, you had to have paid into it for at least 10 years. It is offered for some younger people as well with disabilities and patients that have end-stage renal disease. But generally speaking, Medicare is for the older person. Must be a citizen or permanent resident of the United States. No person is denied coverage based on past medical history. Again, as long as you've paid into your 10 years into Medicare, then you are eligible for Medicare once you turn 65, unless, of course, you have another disability or end-stage renal disease. So Medicare health plans, this is where people usually get confused. All right. So Medicare Part A is hospital insurance for inpatient hospital stays, care in a skilled care nursing facility, hospice care, and some home health. All right. So Part A is your inpatient hospital, your skilled nursing, your hospice care, some home health care. Part B is your medical insurance. All right, this covers your physician services, your outpatient care, medical supplies, your diagnostic tests, your preventative care. Part A is free. It doesn't have a cost. Part B is an additional charge, as is Part C and Part D. Part C is your Medicare Advantage plan. This is actually not a part of Medicare itself. It is offered by private insurance companies that contract with Medicare. And these are like HMOs and PPOs. I'm sure like it's gonna start coming up too because we're getting into the time for Medicare enrollment. You'll start seeing commercials or hearing commercials on the radio for Medicare Advantage plans. This is what you're listening. This is what this is. Um, Medicare Part C can also offer some drug coverage, prescription drug coverage, depending on the insurance company you choose. And like United Healthcare is, one that does a Medicare Advantage plan. But again, this is going to be an additional out-of-pocket cost. And then Medicare Part D is the prescription drug coverage. It is also offered by insurance companies and other private Medicare approved companies. Again, it is not, these are additional that patients get. In addition, that they pay more out of pocket for with their Medicare. Medigap is a private insurance purchased to cover all items Medicare does not cover. And so we do encourage people to get, Medicare, like the Medigap coverage, because, that will help to cover their deductibles, their co-payments, their co-insurance. Can't enroll in C and D. If you have a Medicare Advantage plan that includes prescription drug coverage and you join a Medicare prescription drug plan, you'll be unenrolled from Part C, right? So there's lots of rules that govern Medicare. I am not looking forward to figuring that out. But yes, so A is guaranteed, B is an extra cost, C is the gap insurance basically, and D is prescription. All right, so C and D are not mandatory. They're there as options, but again, they're going to be additional costs for the clients. Medicaid, okay, Medicaid is for eligible families and individuals with low income and resources. So there are specific eligibility requirements that the person must meet. Each state establishes its own program, services, and requirements, including eligibility. Okay, so the state establishes its own program. The federal government establishes broad national guidelines for Medicaid. All right, but it's managed at both levels. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible for Medicaid. And then we have the CHIP. We have Children's Health Insurance Program, which is a program that is under Medicaid, provides medical assistance for eligible children. So it covers children up, depending on their income guidelines. It's free or low cost health insurance for kids up to age 19. And depending on that, CHIP's pretty good program. When I worked in peds, I had a lot of patients or a lot of families that had CHIP coverage. And it was really good. So healthcare, again, as you kind of look into the cost of health insurance, it can be crazy. And it depends on your employer too. Some employers pay more of your health insurance premiums, others pay less. It just depends on the organization. But there's usually always an annual increase in your premiums. The ACA, or the Affordable Care Act, requires the government to create a process in conjunction with state where insurers have to justify unreasonable premium increases. It's crazy. I know people that pay, upwards of $1,000 a month for their health insurance premiums. and still have high deductibles. It is kind of crazy. The uninsured. So the uninsured often includes your low wage employees, so employed in low wage jobs that are less likely to, have or to offer health insurance. The middle class as well. Some of the middle class are unemployed. And those that are employed may be priced out of the health insurance market by just the rising insurance premiums. Like I said, I know people that pay upwards of $1,000 a month for their insurance premiums. So imagine, that's coming out of your check. And that's a pretty good chunk that's taking away, right, from other bills and taking care of families and things like that. So with the uninsured, some of the options, right? If they qualify for Medicaid, if they can afford private pay, if they can find charity care, think it used to be with your, if you didn't pay your medical bills, right, it didn't affect your credit score or things like that, but all of that's being reported now, so it doesn't go on your credit report. And if we don't have access to healthcare, right, then we're not getting preventative care, we're not getting treatment that we need, which can be devastating. It causes a delay of care, and then people are getting diagnosed with diseases at later stage, right, which means it may not be treatable or curable. So unfortunately, like I said earlier, the Affordable Care Act did take a huge chunk, and it did allow a lot of people to become insured, but we still have plenty of people that are not insured. And then we're going to get into, some of the other, so prospective payment systems. Prospective payment systems is a reimbursement that pays a predetermined fixed amount per patient admission, regardless of the actual cost to provide care, right? So it's kind of like, that set fee if they come in for a heart attack, if they come in for a stroke, if whatever it is. The payment amount for the service is based on the classification system, right? Your diagnostic readiness or your diagnosis related groups. And so they kind of know, the hospitals know, like, okay, we have a stroke patient coming in, this is what our reimbursement is going to be. The biggest reason for this is to control input costs and resource use. So it's cost containment, right? So it's simple things like when you're going into a patient's room to do a treatment, right? Don't bring a whole bunch, just bring in what you need and what you're going to use, right? You don't just grab a whole handful of things and go into that resident's room, right? It's utilizing your resources appropriately. Couple things that they, it did criticize it because, a lot of times, people may have been discharged that weren't ready to go home, and then would end up back in the hospital, right? So there's, a downside to both. Your DRGs, right? This is what we're going to pay. All right. So they know exactly how much the hospital knows exactly how much they are going to be reimbursed. And so they get that nice flat fee. So what are some things that the hospital, so think about, this is why we make such a big deal about infection control, right? The patient comes into the hospital and they have a Foley catheter, and they develop a catheter-associated urinary tract infection, right? That hospital is not going to get paid to treat that urinary tract infection, all right? The hospital is going to have to pay to treat that. Same thing if a patient comes in, maybe they had a stroke and preventive measures weren't put into place to prevent that pressure area from occurring. Okay, now the patient has a stage 2, a stage 3. The hospital is not going to get reimbursed for that care for that pressure ulcer, right? Because it was preventable. And so this is some of the, that's why I said it's a focus on quality of care, not quantity of care, right? Doesn't matter if you're, providing, IV fluids and, whatever, if you're not providing high quality care, and, that's usually where they're going to get dinged. With quality, safety, cost of healthcare. So we do have a huge nursing action to improve quality in healthcare. And so continuous quality improvement is one. Has anybody heard of continuous quality improvement before? No, so continuous quality improvement, we are looking at, any incidences or mistakes that were made after they occurred. So let's say there was a medication error, or we had a patient fall, or, something like that. Quality, right? We usually go back and we look and say, okay, what are all the processes? But when we look at continuous quality improvement, we're looking at preventing the problems or the adverse events. So what are things that we can put into place to prevent that patient from falling, to prevent the catheter associated urinary tract infection, to prevent the central line infection, right? So whether it's a checklist, or, another policy or procedure that's put in place. A lot of places have CQI teams, that you may be asked to be part of. We have aims of the Institute of Medicine, which, the 6 aims were to, increase quality in healthcare. You also have your Joint Commission on National Patient Safety Goals, right? So if you remember from community, right, talked a lot about the National Patient Safety Goals. We also have the Transition to Practice Initiative by the NCSBN, to improve quality and safety of healthcare by new grads. And so there's, and the NCSBN developed a transition to practice, when it's set up for acute care settings, which is I think it's like 9 to 12 month program, just to help new nurses or new grads transition into the clinical setting. And there's not every hospital organization utilizes it, but it is a really good program, to help transition new grads into nursing workforce. Long-term care, I have not seen that be implemented. It's mostly in your acute care hospitals. Improving costs of healthcare, cost containment. So this is where I said, don't go in with a handful of supplies when you only need one. You want to, be efficient, you want to be effective. You also want to make sure that you are charging appropriately for, the supplies that you use in your client's care. It's one thing, if you have to go start a Foley catheter and you bring an extra catheter just in case, right? But you don't need to go in with 10 catheters if you go in late, because anything that you bring into a patient's room, right, has to stay in that patient's room. It can't be used for anybody else. So if those supplies are not used, they end up getting thrown in the trash, right? And that could be pretty expensive. Trying to think. Readmissions. So this is something I was mentioning earlier. So when we initially it started with those DRGs, and you're going to get that nice little chunk of money for whatever services are provided to that client, in the emergency room or in the hospital during the hospital stay. There is that was a concern that people were being discharged too soon from the hospital. And we would see it because we would see it in skilled care, in rehab. They'd come in and the hospital would say they were stable, but they really weren't quite stable. And they usually would end up back in the hospital or back in the emergency room. So one of the big quality improvements was to reduce the readmission rate. And so if a hospital discharges a patient and that patient is readmitted within 30 days of the discharge date, then they will get a reduced payment for care for that patient. A lot of them are heart related, like your heart attacks, your heart failures, your COPD, even some of your surgeries, like your hip and knee replacements. Again, this was just an effort to improve transitions of care. And we have the same, even within long-term care, if you discharge them too soon from the skilled facility, right, and they end up back in the hospital for whatever reason, right, we have to look at the readmission rate there. So again, it's all about safety. It is, about what is best for your patients, and all goes back to right? Your critical thinking skills, and, providing, what are the best things that you can do for your clients, and your patients to prevent complications and to provide the most quality care, not quantity, right? What quality care that we can provide to our patients. All right, any questions? All right, so just to recap, this week you have your NCLEX questions, your NCSBN paper is due this week as well. There is no class next Monday. All right, so I will not see you. I will see you again in week 10. Week 10 is going to be your last exam, so make sure that you attend the live reviews. And then week 11 is your HESI week, right? You will have your last set of Saunders or your last set of NCLEX questions due in week 11. And then week 12, we will meet. And then you'll be done. So, any last minute questions?